Have you ever felt like a strange flutter in your chest?
Mm-hmm.
Maybe a pounding sensation that just catches you off guard?
Yeah.
Or perhaps, during a routine checkup, your doctor mentioned hearing a sound when listening to your heart, something that struck them as unusual.
Right.
These are incredibly common experiences, but they can definitely spark concern.
Mm.
What do these signals from our own bodies actually mean? How do we even begin to understand them?
Well, it's a fundamental question in clinical practice, really. These sensations and sounds, palpitations and murmurs, they're often key indicators that require careful investigation.
Mm-hmm.
They can be completely benign or, they can point to something more significant. The challenge, and what we'll explore today, is figuring out which is which.
Absolutely. And that's exactly what we're going to do in this deep dive. You've shared some fantastic source material with us, excerpts from a really important medical text, focusing on sections that deal with, well, the fundamental ways diseases show up. We're going to take a deep dive into Chapter 42, which covers heart murmurs, and then really sink our teeth into Chapter 43, all about palpitations.
That's the big one.
It is. And there's also a small section on dysphagia, or difficulty swallowing, in Chapter 44 that we'll touch on as the source provides.
What's fascinating here is how these seemingly simple physical findings, a sound heard with a stethoscope, a sensation, a patient reports how they can launch a really complex diagnostic process.
Yeah.
Mastering the interpretation of these signals is crucial for understanding cardiac health, and that's what this source material helps us do.
So our mission today is to use these sources to extract the core insights and really go deep, especially as you wanted, into the nuances of palpitations. We want you, the listener, to understand this information at a level that, well, approaches how professionals navigate it every day. It's not just about definitions. It's about grasping the why and the how behind the clinical approach. So, okay, let's unpack this, starting with those sounds doctors listen for heart murmurs.
Right, the sound of a heart murmur. The source starts pretty straightforwardly, the definition. It's an unusual sound heard during the heartbeat cycle, but the key thing the source immediately notes is classification. Not all unusual sounds are the same.
Okay, and the source immediately breaks them down into three major categories based on when they occur within the heart's pumping cycle, right?
Exactly. Timing is crucial.
First, there's a systolic murmur. Systole is when the ventricles, the heart's main pumping chambers, are contracting and pushing blood out. So a systolic murmur happens during that contraction phase.
Correct. Then you have a diastolic murmur. Diastole is the relaxation phase when the ventricles are filling back up with blood. A diastolic murmur is heard during this filling period.
And those are generally more concerning, I gather.
Generally speaking, yes. Diastolic murmurs often point towards more significant pathology than many systolic ones.
Okay. And finally, there's a continuous murmur, which, I guess, as the name suggests,
It does. This sound is heard throughout both phases, systole and diastole. This often indicates a persistent flow of blood where it shouldn't be, maybe between chambers or vessels, throughout the entire cycle.
right. Now, the source dives deeper into these systolic murmurs because they are, well, the most common type. And they have several subtypes with pretty different implications.
Exactly. This is where the classification gets, more detailed, more granular.
Okay, so it lists several specific types within systolic murmurs. There are mid-systolic murmurs that are quiet, graded as 2 or less on that 1 to 6 scale.
Right, the grading scale for intensity.
And the source notes that these are often benign, meaning they might not indicate underlying heart disease.
That's a key point. Often benign. But even within those mid-systolic murmurs, the source distinguishes those that are grade 3 or more louder ones, and the text notes these are likely more significant. So, yeah, intensity definitely matters.
Gotcha. And there are also early systolic murmurs, heard right at the beginning of contraction, late systolic murmurs towards the end.
Yep.
And holosystolic or pansystolic murmurs, which means they're heard throughout the entire systolic phase, like from start to finish.
Right, covering the whole period. The source provides a helpful framework, including a figure 42-9, which outlines an initial strategy for evaluating these based on the type and the patient's overall clinical picture.
Like a decision tree.
Exactly. It's like a decision tree for the clinician. Helps guide the next steps.
Let's walk through that strategy then, because it really shows how the clinician moves from just hearing the sound to deciding, okay, what do we do next? It starts with the basics, what type of murmur, and how's the patient doing?
Okay, so the diagram and text first look at that specific type we mentioned. Mid-systolic, grade 2 or less. This is the category where, a lot of innocent murmurs fall,
Right, the quiet ones.
the quiet ones. So for this specific quiet mid-systolic murmur, if the patient is asymptomatic, meaning no symptoms like chest pain, shortness of breath, anything like that, and has no associated findings suggesting heart disease, and the figure's footnote clarifies other signs, could be like an abnormal ECG or chest x-ray,
Right.
then the source presents a pathway that might sound, well, a bit surprising.
How so?
Well, it clearly states that routine echocardiography, that common heart ultrasound, the TTE or transthoracic echo, is not recommended for these asymptomatic patients with just a grade 1 or 2 mid-systolic murmur and no other signs.
Wow, okay.
In these cases, the diagram even shows a path labeled simply "no further workup" can be appropriate.
That is interesting, because you'd almost assume any murmur automatically gets an echo.
Yeah.
But the source is saying no for this specific quiet type in someone with no symptoms or other issues? Maybe not.
Maybe not necessary as a routine step, but, and this is crucial, the source adds a nuance. It says even in this low-risk group, referral to a cardiovascular specialist could be considered if there is doubt about the significance after the initial exam.
So clinical judgment still plays a big role.
Absolutely. This highlights the art of medicine, right? Especially cardiac auscultation, just listening.
Yeah.
Even with guidelines, if a clinician hears something and isn't 100% sure it's innocent, getting a specialist opinion or maybe considering that TTE, which is still shown as an option on the diagram,
Right.
might still be the right call. It's that judgment overlaid on the framework.
Okay, so that's the path for the quiet, asymptomatic, mid-systolic murmur. But what about if the patient is having symptoms or does have other signs of potential heart disease, regardless of the murmur type or how loud it is?
Then the pathway shifts significantly. The diagram and text indicate these patients need more detailed investigation pretty much right away.
And the tests listed are more involved.
Yes. The diagram mentions things like transesophageal echocardiography, or TE, cardiac MR magnetic resonance imaging, or even cardiac catheterization, noting they're used if appropriate.
So symptoms or other signs automatically raise the suspicion level.
Definitely. It suggests a higher likelihood that the murmur is linked to a real structural or functional problem that needs a deeper look than just the basic exam can provide.
Okay. The figure also briefly lists a couple of other specific murmur types, like venous hum and mammary souffle.
Yeah, it mentions them. Venous hum is often heard in neck veins, especially in kids. Mammary souffle can be heard over the breast, often during pregnancy or lactation. The source includes them as types of murmurs, so they fit into an evaluation somewhere, even if this particular flowchart focuses more on the common valve-related murmurs.
Got it. So beyond just listening and the initial assessment, the source spends quite a bit of time on the role of imaging technologies in evaluating these murmurs. Echo seems central.
Oh, absolutely. Echocardiography, both TTE and T, is key. Transthoracic echo, TTE, the standard one from the chest wall. The source calls it central for longitudinal assessment.
Longitudinal meaning over time.
Exactly. For asymptomatic people known to have valvular heart disease, TTE is how you monitor how that valve problem is progressing year after year, say.
And that helps decide on surgery timing.
Hugely. The source notes TTE provides critical information that heavily influences decisions about the timing of surgery. It helps doctors see, okay, when has this valve issue become severe enough that we need to intervene?
But again, it reinforces that point about not using it routinely for everyone.
Right. It hammers home that point.
Fair.
Routine TTE is not recommended for asymptomatic folks with just that quiet grade 1 or 2 mid-systolic murmur without other signs. The testing should be guided by the clinical picture.
Okay. Now, transesophageal echocardiography, TE, you mentioned that as a step up.
It is. T involves putting a probe down the esophagus, the swallowing tube, which runs right behind the heart.
Ah, okay.
The source explains T is used for further evaluation when TTE is limited. And what limits TTE? Well, things like a patient's body size, maybe their chest shape, other stuff in the chest, making it hard to get good ultrasound pictures through the chest wall.
So T basically gets a clearer, unobstructed view because it's right behind the heart.
Precisely. Because it's so close, TE offers enhanced sensitivity for picking up a wide range of structural cardiac disorders. It can spot details or issues that might be fuzzy or missed on a TTE.
Makes sense. The source also details tests, even beyond echo, right? Like advanced imaging.
It does. It talks about electrocardiographically gated cardiac magnetic resonance, or CMRO.
Mm-hmm.
The source really emphasizes its strength, providing quantitative information. It's not just pictures, it's measurements.
Quantitative, like
Yeah.
specific numbers.
Exactly. The source lists a whole bunch of things CMR can measure precisely. Valvular function, regurgitant fraction, that's the percentage of blood leaking backward,
Okay.
regurgitant volume, the actual amount leaking, shunt flow between chambers, chamber and vessel size, ventricular function, how well the pumps are squeezing, even myocardial perfusion, which is blood flow to the heart muscle itself.
Wow, that's a ton of specific data.
Yeah, it really is. And here's a really key point the source makes about how this tech changes practice. It states that CMR imaging has largely supplanted the need for cardiac catheterization and invasive hemodynamic assessment in certain situations.
Really? Supplanted invasive tests. In which situations?
The source specifies it's often when there's a discrepancy, like between the clinical findings, what the doctor hears and sees, and what the echocardiogram shows, especially in patients with regurgitant heart valve disease.
So leaky valves, like mitral regurgitation or aortic regurgitation.
Exactly. Before CMR became widespread, if the clinical picture and the echo didn't quite line up on how bad the leak was, you might have needed an invasive cath to measure pressures and flows directly inside the heart. Now, CMR can often give you that definitive quantitative data non-invasively.
That's a huge shift, using non-invasive tech to avoid a more invasive procedure. The source mentions cardiac CT playing a similar role sometimes too.
It does. Both CMR and cardiac CT can be useful when TTE isn't clear on certain things, like is the aortic valve bicuspid 2 leaflets instead of 3? They can also give really detailed anatomical pictures of the aortic root, the base of the aorta, and the ascending aorta.
And there's a specific mention of coronary CT angiography, CCTA.
Yes, the source highlights a specific use case for CCTA to rule out coronary artery disease, blockages in the heart's own arteries, in selected patients before they undergo other invasive procedures like a cath or surgery.
So it's like a non-invasive screening check for coronary blockages before a bigger procedure.
Kind of, yeah. In specific situations where knowing about coronary disease is critical beforehand.
Okay. So even though CMR has taken over some roles, the source still mentions cardiac catheterization or invasive hemodynamic assessment. It's not totally gone.
Not totally obsolete, no. The source notes it might still be required for a more complete preoperative evaluation in certain complex cases where even TTE and the clinical picture aren't enough. Its role has definitely changed, but it's still in the toolkit for specific situations.
Right. Now, the source also brings up some newer technologies, framing them more as additions, maybe, than replacements for the stethoscope.
Yeah, as potential augmentation rather than wholesale replacement. That's the phrasing used.
Like those handheld or miniaturized cardiac ultrasound devices. The source says some clinicians are actually using these instead of stethoscopes sometimes.
It does mention that. And reports suggest they might improve sensitivity for detecting certain conditions like rheumatic heart disease in susceptible populations. But, and these are big buts, the source adds crucial caveats.
Okay, what are the caveats?
First, accuracy is highly operator dependent. Just like using a stethoscope wall takes skill and practice, so does using these handheld devices effectively.
Makes sense.
And second, importantly, the source points out that the cost implications and the actual effects on patient outcomes haven't really been nailed down yet for most common scenarios. Are they worth the extra cost? Do they actually lead to better health? The evidence isn't fully there for widespread replacement.
So the source's stance is more like use them selectively.
Exactly, selective augmentation. Use them when they add specific value to the physical exam rather than throwing out the stethoscope entirely. They're potentially helpful tools, but not necessarily a universal upgrade yet.
Okay. Another tech mentioned is electronic or digital stethoscopes, maybe with a visual display.
Right, sometimes with a spectral display showing the sound waves visually. These are proposed as ways to maybe improve characterization of murmurs, help distinguish subtle features, and also potentially for mentored teaching.
Teaching? How so?
Imagine a student listening and seeing the sound pattern on a screen simultaneously, with an experienced mentor pointing things out. It could potentially enhance both diagnostic skill and the learning process itself.
Interesting. So putting it all together, the source outlines this kind of integrated approach to evaluating murmurs. Starts basic, adds tech when needed.
That's exactly it. The process, as laid out, absolutely begins with systematic cardiac auscultation. Careful listening with the stethoscope.
And by characterizing the murmur timing, intensity, location, how it changes the clinician, starts building a list of possibilities.
A preliminary differential diagnosis, yeah, based just on the sound. But then that list gets refined. You integrate information from the patient's history, their symptoms, risk factors,
Okay.
any associated cardiac findings from the exam or basic tests, the general physical exam, and the overall clinical context, you're placing that sound within the whole patient picture.
And then you decide on further testing, echo, CMR, whatever, based on how suspicious things look at that point.
Right. The testing follows logically, driven by the need and urgency identified in that initial integrated assessment.
And the source really emphasized something about correlating the listening findings with the imaging, an educational feedback loop.
Yes, that's a fantastic point it makes. By listening, forming an idea, then getting the echo or CMR and seeing the actual anatomy and function, and then comparing, that's what that sound was, the clinician gets better at interpreting the sounds next time.
So the tech helps you become a better listener.
Exactly. It's using the imaging to constantly refine your physical exam skills. It's a feedback loop for learning and improving.
That's really neat. Of course, the source also brings in real-world stuff, like cost. Testing needs to be justified.
Right. Non-invasive imaging isn't free. It has to be justified by its incremental contribution. Is this test likely to change the diagnosis, the treatment plan, or the outcome? You don't just order tests for the sake of ordering them.
And despite all this amazing technology, the source still comes back to the value of the stethoscope.
It does. It calls it a time-honored tradition, notes its benefits go beyond just the sounds it's part of, connecting with the patient. It's efficient for initial assessment.
So the overall picture for murmurs is: start with careful listening, integrate everything else about the patient, use tech smartly when it adds value, and keep learning from the results. A blend of old skills and new tools.
Perfectly summarized. It's a structured approach, drawing on guidelines, research, clinical experience, the whole body of knowledge.
Okay, that gives us a really solid, deep understanding of heart murmurs and their evaluation based on this text. Now, let's shift gears completely. Let's move to something you might actually feel: palpitations. This is chapter 43, the one you really wanted to dive into, aiming for that professional level of detail.
Yeah, let's do it. The palpitations are, just incredibly common. One of the top reasons people see a doctor. The source defines them as that unpleasant awareness of your own heartbeat. Patients use all sorts of words.
Like thumping or pounding.
Right. Thumping, pounding, racing, skipping, fluttering in the chest, that kind of thing.
And the source notes they can be intermittent, sort of off and on, or sustained,
Yeah.
lasting longer.
And regular or irregular.
Exactly, all those variations. And it points out that patients often get particularly concerned about those feelings of skipped or missing heartbeats.
Yeah, that would feel unsettling.
It definitely can be. And they're often noticed most when someone is just quietly resting, Fewer distractions, so you become more aware of your body. The source also mentions positional palpitations, felt only in certain positions.
It does, and notes these can sometimes hint at a structural process, maybe pressing on the heart or related structures in that specific position. Worth noting.
Okay, now, to really understand palpitations like a professional, we need to get into the causes. And the source gives this really crucial breakdown, citing percentages from a large study.
This breakdown is, fundamental for the clinical mindset. According to that large series they mention, cardiovascular causes, about 35%.
About a third.
Psychiatric causes, this was the biggest group, 43%.
Wow, nearly half.
Miscellaneous causes made up another 10%, and then in 16% of cases, the cause remained unknown, even after evaluation.
That 43% for psychiatric causes is huge. It really underscores that while your first thought might be heart attack, often it's related to anxiety, panic, or similar issues.
Absolutely. It doesn't make the symptom less real or distressing for the patient, not at all, but it heavily influences the diagnostic approach and probabilities.
Okay, so let's dive deeper into each category. Starting with the cardiovascular causes, that 35%.
Mm-hmm.
What specific things does the source list there?
Okay, so cardiovascular causes include premature atrial contractions, PACEs, and premature ventricular contractions, PVCs. Those are the very common extra or skipped beats.
Right.
Then more sustained or rapid abnormal rhythms, supraventricular arrhythmias, things like SVT or VT,
Okay.
conditions like mitral valve prolapse, sometimes with associated arrhythmias, aortic insufficiency, that leaky aortic valve we talked about with murmurs, Less common things like atrial that benign tumor in the atrium, inflammatory conditions like myocarditis, and even occasionally a pulmonary embolism can present with palpitations.
So quite a range of heart-related issues. Now, the source gives a really detailed explanation for why we actually feel those intermittent paces or PVCs. It's not always the extra beat itself.
That's right. This is a fantastic physiological detail. It explains the patient often doesn't sense the premature beat itself, but rather the beat immediately following it, the post-extrasystolic beat.
Okay, why is that beat felt so strongly? What's happening?
Two key reasons, according to the source. First, the premature beat comes early, right? So there's a longer pause before the next normal beat. This longer pause lets the ventricle fill with more blood than usual. So its end diastolic dimension, how stretched it is before it pumps, increases. It's fuller.
Okay, more blood in the chamber. And the second reason?
The second reason is something called post-extrasystolic potentiation. Because of that longer filling time and other cellular mechanisms, the strength of the contraction of that next beat is significantly increased.
Like the heart gives an extra hard squeeze.
Exactly. Think of it like pulling a slingshot back further, the stone flies harder. So you have a fuller chamber contracting with extra force. That's the beat the patient often perceives as a thump or pound.
I get it now. It's the combination of the pause, the extra filling, and the stronger beat after the skipped one. That really clarifies the sensation.
It does. It links the physiology directly to what the patient feels. The source also differentiates the sustained palpitations, the ones that go on for a bit, regular versus irregular.
Right. If it's sustained and feels regular, like a fast, steady drumbeat.
The source says that's likely caused by regular supraventricular or ventricular tachycardias, fast rhythms, but with a steady, regular pattern.
And if it's sustained but feels totally irregular,
chaotic.
then the prime suspect, according to the source, is atrial fibrillation.
Okay. Now, here's a really important point the source makes, kind of a reality check. It explicitly states that most arrhythmias are not associated with palpitations.
Yes. This is so crucial for context. Lots of people have occasional PVCs, PTS, even short bursts of fast rhythms, and they never feel a thing. Their brain just filters it out.
So feeling palpitations doesn't automatically mean you have a dangerous arrhythmia.
Correct.
And having an arrhythmia doesn't automatically mean you'll feel palpitations. The correlation isn't one-to-one. Not at all, it's subjective. The source also lists hyperdynamic cardiovascular states as another cause. Situations where the circulation is just working overtime.
Like being amped up.
Basically, yeah. Often driven by increased catecholaminergic stimulation adrenaline, noradrenaline. The examples given are exercise, stress, and a condition called pheochromocytoma, a tumor releasing those hormones.
So in those states, the heart beats faster and harder, and you just become more aware of it. That's the palpitation.
Pretty much. Increased heart rate and force of contraction make the heartbeat more noticeable.
The source mentions athletes, especially older endurance athletes, often get palpitations.
It does. And while it doesn't explicitly spell out why right there, you can connect it back to that hyperdynamic idea. Athletes often have very strong heart contractions, maybe a lower resting rate, which might make them more sensitive to changes or extra beats. Physiological adaptations.
Okay. Another specific condition mentioned is aortic regurgitation, AR. How does that cause palpitations?
With significant AR, the left ventricle often enlarges to handle the leaky valve. This, combined with what the source calls a hyperdynamic precordium, frequently leads to palpitations.
Hyperdynamic precordium. That means you can actually see or feel the chest moving more forcefully with the heartbeat.
Exactly, because the enlarged ventricle is pumping a larger volume of blood quite forcefully. That strong physical movement contributes to the sensation.
And then there's this critical list of substances and factors that can just ramp up the heart's contraction or weight and trigger palpitations.
Yeah, this is huge for history-taking. Things like tobacco, caffeine, a big one, aminophylline, atropine, excessive thyroxine, thyroid hormone.
Like in hyperthyroidism or taking too much medication.
Right. And illicit drugs like cocaine and amphetamines. Asking about these is absolutely key. You see the overlap again. Thyroxine ties into thyrotoxicosis. Pheochromocytoma is also hyperdynamic. Causes aren't always neatly separate.
Okay, let's move to the psychiatric causes. That huge 43% number.
Yeah.
What specific conditions are listed?
The source lists panic attacks or disorders, generalized anxiety states, and somatization disorder, where psychological distress manifests as physical symptoms. These can occur alone or together.
And the source gives a clue for telling these apart clinically, something about duration.
Yes, a potentially useful clue. It says patients whose palpitations stem from psychiatric causes more commonly report a longer duration of the sensation, often specifying more than 15 minutes. And they also tend to have other accompanying symptoms consistent with anxiety or panic compared to patients whose palpitations have other causes.
So longer duration plus other anxiety symptoms might point towards a psychiatric component.
It's a suggestion, yeah. A clinical pearl from the source.
Okay, then the miscellaneous causes category, that 10%, what's in there?
With a bit of a mixed bag. Thyrotoxicosis, overactive thyroid. Various drugs, again, drugs fit multiple categories. Ethanol, alcohol, spontaneous skeletal muscle contractions of the chest wall.
Like a muscle twitch, but in your chest wall.
Exactly. Can feel like a flutter. Pheochromocytoma is listed in here too, and systemic mastocytosis, a rare immune cell disorder.
And finally, that 16% where the cause remains unknown.
Right. Important to acknowledge that even with a thorough workup, sometimes a definitive cause just isn't found.
Okay, so appreciating this huge spectrum of causes, from life-threatening arrhythmias to benign skips, anxiety, coffee is step one. Now, how does the source outline the clinical approach to actually evaluating a patient who comes in with palpitations?
The absolute principal goal, right at the top, stated clearly. Determine if the symptom is caused by a life-threatening arrhythmia. Safety first. Everything else follows from that.
And how do you identify who's at highest risk for that?
The source points directly to patients with pre-existing coronary artery disease, CAD, or those with significant risk factors for CAD. If someone with known heart problems or major risk factors reports palpitations, your antenna goes way up. The concern level is much higher.
Got it. And what about associated symptoms? Are there warning signs that come along with the palpitations?
Yes. Big warning signs suggesting hemodynamic compromise, meaning the heart rhythm is affecting blood flow, are syncope, fainting, or lightheadedness. Palpitations plus feeling like you're going to pass out. That's a red flag for a serious issue.
Makes sense. What about other symptoms that might occur with sustained rapid rhythms, tachyarrhythmias?
If a patient with a known CAD has a sustained rapid heartbeat, it can cause angina pectoris, chest pain because the fast rate stresses the heart, or dyspnea, shortness of breath.
Okay.
And the source also explains why dyspnea happens with rapid rhythms in patients with other specific heart conditions, like ventricular dysfunction, weak pump, aortic stenosis, narrowed valve, hypertrophic cardiomyopathy, thick muscle, or mitral stenosis, narrowed valve.
Right. You mentioned this earlier with murmurs, too. The rapid rate messes with filling.
Exactly. These conditions already impact filling or emptying. A very fast heart rate gives even less time for the ventricles to fill properly. This causes pressure to back up into the left atrium than the lungs, leading to congestion and shortness of breath. The fast rate makes the underlying problem worse acutely.
So the accompanying symptoms give huge clues about the severity and impact. What about the physical examination itself? What are you looking for?
Key things are measuring vital signs, heart rate, blood pressure, assessing the jugular venous pressure and pulse in the neck for clues about right heart pressures, and auscultation, listening to the chest and heart for murmurs, extra sounds, signs of fluid in the lungs.
And the goal of the exam here is?
Twofold, according to the source. 1, help confirm or refute if an arrhythmia is actually happening. 2, assess its adverse hemodynamic consequences. Is it causing problems right now? Low blood pressure, backup.
The source also offers some really practical, active things the physician can do during the interview itself.
Yes, these are great clinical tips. First, ask the patient to tap out the rhythm they feel.
Just tapping on the table.
Yeah. Simple but surprisingly effective. Is it fast? Slow? Regular tapping like a metronome? Or totally irregular like random drumming? It gives an immediate sense of the rhythm's character.
That's clever. And the other tactic?
If possible, take the patient's pulse during an episode. If they happen to feel palpitations while they're right there with you, feel their wrist pulse or listen to their heart. That direct correlation between the symptom and the objective rhythm is gold standard information.
Right. Capture it in the act. Okay, so you've got history, risks, symptoms, exam, tapping. Then you move to diagnostic testing, especially if you need to actually document the suspected arrhythmia because it's not happening right now.
Exactly. The baseline test is the resting electrocardiogram, the ECG or EKG, records about 10 seconds of electrical activity. Its job is to document the arrhythmia if it happens to occur during that brief recording window.
But palpitations are often sneaky. They don't perform on command. What if they only happen with exercise?
Then the source mentions exercise electrocardiography, a stress test. If exertion triggers the palpitations, you put the patient on a treadmill or bike, monitor their ECG, and try to provoke and capture the arrhythmia.
Okay. But what about the really tricky ones? The arrhythmias that pop up randomly, maybe just for a few seconds once a week, or even less. This is where the source goes into real detail on monitoring strategies,
Hmm.
critical for that professional level understanding.
Absolutely critical. Because this is so common, the first method discussed is continuous electrocardiographic monitoring, the Holter monitor, usually worn for 24 or 48 hours, continuously recording.
But the source points out a limitation for infrequent palpitations.
It does. It explicitly states that Holter monitoring is of limited clinical utility for palpitations that happen infrequently.
Because the recording window is too short.
Exactly. If your symptom only occurs once a week, the odds of catching it in a single 24 or 48-hour period are pretty low. You need longer monitoring for those cases.
So what are the options for longer monitoring? The source mentions telephonic monitoring.
Right. With these, the patient typically has a device, maybe wears electrodes. When they feel symptoms, they activate the device, it records a short ECG strip, and then they transmit it, often over the phone or wirelessly for analysis. This lets you monitor for weeks, potentially.
Okay. Then there are loop recordings,
Uh,
external or implantable.
Yes. Loop recorders continuously monitor the ECG, but only save specific events. They keep a loop of the last few minutes in memory. When an event happens, either the patient pushes a button because they feel symptoms, or the device automatically detects a very fast or slow rhythm. It saves the ECG from shortly before, during, and after that event.
And the implantable loop recorder, the ILR, gets a specific evaluation in the source. It's placed under the skin.
It is. Small device, minor procedure. The source describes ILRs as safe. And importantly, possibly more cost-effective for assessing patients with infrequent, recurrent, unexplained palpitations.
More cost-effective.
Even though it's implanted.
Why?
Think about it. If someone has palpitations only once every few months, doing repeated Holters or external monitors might cost a lot and still miss the event. An ILR can stay in for up to 2 or 3 years. Massively increases the chance of finally capturing that rare event and getting a diagnosis, potentially saving money on endless repeat testing or other workups down the road.
Ah, okay. Longer surveillance window pays off for the really infrequent ones. Makes sense. The source also mentions mobile cardiac outpatient telemetry, MCOT.
Yeah, MCOT systems are typically worn externally for maybe 2 to 4 weeks. They often automatically detect arrhythmias and allow patient activation. Recordings are usually transmitted wirelessly for near real-time review. The source also describes these as safe and possibly more cost-effective for infrequent, unexplained palpitations, similar niche to the ILR, but external.
Now, for all these monitoring types, Holter, telephonic, loop, MCOT, the source hammers home one absolutely essential component for making sense of the data.
Yes. And the patient's role here is crucial. They must keep a detailed diary or use the electronic marker function on the device to note the precise time they experience symptoms.
Why is that timing so critical?
Because the device might record hundreds of little blips or rhythm changes over weeks, the clinician needs to know which specific electrical event, if any, actually corresponds to the fluttering sensation you felt at 3:17 p.m. on Tuesday. Without that patient-provided timestamp and symptom description, you're just looking at a sea of ECG data with no clinical correlation. The diary connects the subjective feeling to the objective recording.
Got it. The patient's careful tracking is non-negotiable. Okay, so we've covered causes, approach, risks, exam, tapping, the whole range of tests, especially for intermittent symptoms. What about management and outcomes? What happens after the evaluation?
Well, the source offers a really reassuring perspective for most people. It states clearly, most patients presenting with palpitations do not have serious arrhythmias or underlying structural heart disease.
That's the key takeaway, really. Often, the worry is much worse than the actual underlying issue.
It often is. Now, if the evaluation confirms the palpitations are benign, say just occasional extra beats, PS, PVCs, but they're still bothersome,
Yeah, what can be done then?
the source notes that if they're sufficiently troubling, beta blocker therapy can often help manage the symptoms, reduce the sensation.
Okay. And what if they're triggered by external factors, like the substances you listed?
If it's things like alcohol, tobacco, illicit drugs, the management is conceptually simple, though maybe hard in practice. Abstention. Stop using the trigger substance. If it's a prescribed medication causing them, the approach is to work with the doctor to consider alternative therapies if possible. Find a different drug that doesn't cause palpitations.
And for the biggest category in that study, the psychiatric causes, anxiety, panic.
The source suggests that those patients may benefit from cognitive therapy, Talk therapy focused on managing thoughts and responses, or pharmacotherapy, medication to treat the underlying anxiety or panic disorder.
Finally, the source acknowledges the patient experience itself. Palpitations feel bothersome, sometimes frightening.
Definitely. It's an unusual sensation. And that's why the source emphasizes the physician's crucial role in providing reassurance once serious causes have been ruled out. The patient should be reassured that these benign palpitations will not adversely affect prognosis. That reassurance itself is a key part of the therapy.
Right, reducing the anxiety about the symptom itself. So really mastering palpitations based on this source means knowing that huge range of causes, knowing psychiatric is most common, understanding the why behind the feeling like post-extrasystolic potentiation, spotting the red flags, using the exam and history tricks, choosing the right test for the frequency of symptoms, understanding the cost-effectiveness arguments for things like ILRs, and knowing how to manage based on cause, including that vital reassurance.
Exactly. It's integrating everything: history, exam, targeted testing, interpretation and context, like solving a complex puzzle where the answer might be simple or complicated, but you need a systematic way to find it. And this knowledge comes from accumulated experience and research, like the references in the source.
All right, fantastic deep dive into murmurs and especially palpitations, hitting that professional level detail. Lastly, the source material also included that chapter on dysphagia, difficulty swallowing. Less detail here, mainly definitions.
Correct. Chapter 44 introduces dysphagia, starts with the core definition: difficulty swallowing food or liquid anywhere from the mouth-throat down the esophagus.
Then it notes the potential impact: nutrition, aspiration risk.
Yeah, briefly mentions it can compromise nutrition, cause aspiration, food liquid into lungs, and reduce quality of life. Serious potential consequences.
But the main focus seems to be defining related terms accurately, like aphagia.
Aphagia means complete inability to swallow. The source says this usually points to a total blockage, often a food bolus stuck in the esophagus.
Okay, and ogdenophagia, that sounds painful.
It is. Odonophagia means painful swallowing, usually due to irritation or ulceration in the swallowing passage lining. The source notes it often occurs with dysphagia, but you can have dysphagia without pain.
Got it. Then there's globus pharyngeus. This one sounds different.
It is quite different. Globus pharyngeus is described as a sensation of a lump or foreign body in the neck. But crucially, the source states it does not interfere with the act of swallowing, and sometimes swallowing even relieves the sensation.
So it's a feeling, not a physical blockage preventing swallowing.
Exactly. Often related to anxiety or muscle tension, not a true swallowing problem. Important distinction.
What about transfer dysphagia?
Transfer dysphagia specifically refers to trouble initiating the swallow, moving food from the mouth to the back of the throat. The source notes it often leads to things like nasal regurgitation, stuff coming up the nose, or pulmonary aspiration right during the swallow, characteristic of oropharyngeal dysphagia problems high up in the throat-mouth area.
And lastly, phagophobia.
Phagophobia is a fear of swallowing or refusal to swallow. Can be psychological or based on anxiety about choking or pain from past experiences. It's the fear itself preventing eating, not a physical blockage.
Okay. The source then just starts to touch on the physiology,
Right.
mentioning the voluntary oral phase chewing, mixing with saliva, but doesn't go much further in this excerpt.
Right. It sets the stage, introduces the symptom and key related terms very clearly, defines them precisely, but doesn't delve into the evaluation or management of dysphagia with the same depth as it did for murmurs or palpitations in the provided text. It's a foundational introduction.
Okay, well, that brings us to the end of this really in-depth exploration based on the source material you shared. We covered a lot of ground, from the sounds a doctor hears to the feelings a patient experiences, and even a bit about swallowing.
We really did. We went through the systematic approach to heart murmurs, classification, evaluation strategy, the whole range of diagnostic tools from echo to CMR and cath, understanding why and when based on the source. Plus, that great point about the educational feedback loop.
And we definitely hit that deep dive on palpitations, breaking down the huge list of causes: cardiovascular, psychiatric, miscellaneous, unknown. Understanding the physiology of the sensation, the red flags, the exam clues, the monitoring strategies, especially for infrequent events, including the source's take on ILRs and MCOT cost effectiveness, and finally the management approaches and the importance of reassurance.
And we clarified those key definitions related to dysphagia, aphagia, odonophagia, globus, transfer dysphagia, phagophobia, getting the terminology straight based on the source.
So by going through this material at this level of detail, you, the listener, have hopefully gained a much richer understanding than just a quick overview. You've got the specific terms, the relative frequencies, the physiological insights, and the clinical frameworks professionals use.
It really shows how having this kind of structured knowledge helps make sense of complex bodily signals and the process used to investigate them.
So here's a final thought to leave you with. Considering just how incredibly varied the causes of palpitations are, I mean, ranging from that very specific feeling of a post-extrasystolic beat all the way to anxiety or something as simple as caffeine, how does really understanding that vast spectrum maybe change how we think about other common, everyday bodily sensations? And perhaps, how does it reinforce the value of that careful, thorough clinical evaluation, even for symptoms that, quite often turn out to be benign?
It definitely underscores the complexity we live with every day and the importance of not jumping to conclusions, but really listening and investigating systematically.
Absolutely. That's all for this deep dive.